Dr. Edward.
Actually, it is the most difficult topic to discuss. Monitoring microcirculation at the bedside. We intubate, ventilate, we give fluids, we start vasopressors, inotropes. Ultimately, our aim is to improve the oxygen delivery to the tissues. When we don't know what is happening in the microcirculation, whatever the global oxygen delivery, whether we don't know whether it is really hitting microcirculation or not. So to monitor microcirculation at the bedside, we discuss topic, we call Dr. Vijayanand. Dr. Vijayanand have credential of design a protocol of management of patient with traumatic brain injury in surgical ICU in CMC Vellore, expertise in handling simulation lab and has experience in conducting simulation-based ventilator workshops in many institutes.
You can use it.
Vijayanand got MT Bhatia a gold medal for pain management in Madhya Pradesh. Over to Vijayanand.
Thank you so much. As Doctor has explained, this is a very difficult topic to talk at the time at 5 o'clock. It's at the end of the program, so you all must be very tired. At this onset, I'd like to thank the organizing committee for having me at this occasion. Thank you so much. And I also like to thank all these participants sitting at this time to listen to the lecture. So I am from Madurai, and as I told you, I'd like to thank the organizers. I have nothing to disclose here. And when they were calling me, they told me that if they wanted me to speak on microcirculation, this was the road which I was looking at, because there are multiple things to look at it, and how I was going to explain to the PGs, because I have also gone through the same scenario when I was a postgraduate. Trying to explain all this concept is very difficult. I'll try to make it as simple as possible. I'm an practice intensivist for the past 15 years, so this is like what we say for surgeons, is appendix is bread and butter. Similarly, community acute pneumonia coming in a shock to your ICU is my bread and butter. So still we have our day one patient was a diagnosed case of community acute pneumonia, as already in your ICU. He is not responding to any of the therapy. His BP is sitting at a map of 56, and his oxygenation is having oxygenation failure. PP is at 12. He is already on adequately resuscitated fluids and vasopressors. You're struck. You're perplexed. What to be done next for this patient? That is a question you always have here, right? We are given the maximum supports, we are given the maximum fluid challenges, still the patient is not responding, where we are failing. That question is always there. And we try to understand a patient coming in a septic shock. These are the major things. The main thing is your vasodilatation. So because of the vasodilation, there is going to be a decrease in arterial pressure. And that arterial pressure is going to cause something called as tissue hypoxia, ultimately going to lead to something called as cell necrosis. And we try to think, okay, maybe my heart is failing. I'll try to optimize my preload by increasing your fluid challenges. I try to optimize my contractility by using your inotropes and increase the cardiac output. That is actually what we do here. But we don't do much for the tissue hypoxia and cell necrosis. We don't have anything at present to deal with this component. This is where we are failing. We are seeing that we have optimized maximally. We are given adequate resuscitation. We are given adequate maximum supports to this patient, but it still doesn't respond to your therapy, and ultimately we lose the patient. So where we are losing, the point where we are losing is we are not targeting the tissue hypoxia. We're not trying to target the cell necrosis. So as I told you, we are trying to just look in the macrocirculation. Like we are trying to target your mean arterial pressure, CVP. They're trying to use modern machines to target the cardiac output. Trying to look at the mixed venous oxygen saturation and central oxygen saturation. But what the studies have shown that there is actually a dissociation between these parameters. What you see in a macrocirculation and what you see in a microcirculation. And there are techniques that allows to direct viewing of the microcirculation, which is not completely disseminated. And they are not incorporated into your patient management in your daily basis. The main concept is, the studies have shown, even though you optimize your macrocirculation, the microcirculation still at the lower level, it's not responding to your therapy. And we don't have any kind of assessment tools at the bedside to see what we can do for the microcirculation. So as such, some basic anatomy. Microcirculation basically consists of a branching network of small blood vessels, less than 100 micrometer. It consists of capillaries, arterioles, venules. It also consists of your endothelium as well as glycocalyxes. And main mechanism, if you think of a patient, if I am trying to optimize my cardiac output, basically I am trying to make the delivery of oxygen to the tissues to be optimized. That is the main concept. If I say my cardiac output is optimized, my concept is I have given adequate oxygen to the tissues. So That concept is basically based upon the convective flow as well as the passive diffusion of oxygen. What do you mean by convective flow is basically how the passage of red blood cells happens at the level of the tissue, and passive diffusion of oxygen occurs from these RBCs into the cells. That is the two concepts at the level of microcirculation. So as I told you, convection flow refers to the transport of oxygen carrying RBCs to the capillaries, and passive diffusion refers to the transport of oxygen from the RBCs into the capillaries at the tissue level. So what you're trying to do is, whenever a patient is hypovolemic, when the patient does not respond to your therapy, we try to optimize the convective flow. What do you do? We think the patient is hypovolemic, we try to give more fluid. Okay, my patient is anemic, we try to give more amount of Paxil or RBCs, something to optimize the convective flow. But we don't target the diffusion level. So what I'm trying to do is both convective and diffusion flow has an equal contributive effect on the transport of oxygen to the tissue level. This is where we are lagging when you come to manage a patient in a shock. Hence, microcirculation plays a very important role in controlling the vascular resistance, blood coagulations, and inflammatory process, including the immunological barriers. And what the studies have shown that even a smallest degree of microvascular abnormality has been called the organ dysfunction, and the patient does not respond to your therapy, and they died because of this microcirculation failure. Additionally, even what they're saying is, even this macrocirculation failure, even before it happens, if you start targeting the microcirculation, you can find that the tissue hypoxia has already started happening at the tissue level. So what are the types? There are two types of microcirculatory failure that can happen directly because of septicemia, or indirectly because of your macrocirculatory, what Sir was telling about the cardiogenic shock or obstetric shock. As it already states, as a global change, and this vascular bed may be responding differently to your therapy. That means either by shunting of the blood or by vasodilation. That needs to be assessed. Still, we don't have any kind of assessing tool to see whether my blood is getting shunted or whether there is vasodilation at the tissue level. For example, what I meant is, if there is a patient is in a shock, what actually the skin, the muscle, and splanchnial sections will do is, they will respond by causing vasoconstriction during the early phase of hypovolemia, so that I can divert my blood to the essential organs. That is what the usual tissue level happens. And there is also heterogeneity of perfusion. What do you mean by this word heterogeneity of perfusion is basically, if you look at the tissue level, as I told you, microcirculation is basically capillaries, arterioles, and venules. One capillaries might be completely dilated, one might be completely vasoconstricted, one might be inefficiently perfused. This is called as heterogeneity perfusion, and it's a dynamic process. It keeps changing. The venules or arterioles, which was dilated initially as initial phase of your resuscitation, becomes vasoconstricted, again goes into type of dilatation and vasoconstriction. That's why it's a dynamic process. So we have a challenge in the measurement of this process. We don't know how to measure the tissue level. So as I told you, microcirculatory abnormality can contribute many things. A patient coming with the shock, leukocyte abnormalities, any change in the RBCs, mitochondrial dysfunction, coagulation, all this can contribute to microcirculation. Ultimately, you may have any one of this component. Leaky capillaries, what happens in ARDS, where you have interstitial edema, cellular edema, which leading to cellular dysfunction, and last is a microdyspersion, basically shunting and redistribution of blood to the other organs. This is the basic concept of microcirculatory failure. When you look at the assessment of microcirculations, my topic is only assessment. I'm not going to tell you how to manage using microcirculation assessment. So I've got direct method like surface measurement, 3D imaging, regional measurements. Indirect methods includes lactates, mixed venous oxygen saturation, veno arterial CO2 differences. Dynamic method includes occlusion tests and tissue measures like NRS and regional capnography. Our interest will be at looking at the lactates, venous saturations, and the veno arterial CO2 difference. Much has been talked about lactate, so I will not be going to the lactate thing. I will be trying to concentrate on the two important components of mixed venous oxygen saturations as well as the veno arterial CO2 differences. As I already told you, shock is a state of condition. There is an imbalance between your systemic oxygen delivery to the demand. That is the main concept whenever you are dealing with a patient of shock. Let us consider how this can be explained like a train. This is your loading station. This is your unloading station. And you have got an hemoglobin train. The hemoglobin, you know that hemoglobin has got four bonding area of oxygen. So you have got four berth. So four oxygen molecules will occupy each of the hemoglobin molecule, and the train is filled up with the cardiac output is your engine. It is ultimately going to deliver your oxygen to the tissues. This is the normal physiology. It's an easy way to understand. So what happens is, most of the time, the body consumes, if you give 1000 ml of blood, the tissue is going to consume only 250 ml. Ultimately, the 750 ml of oxygen is going to come back to your systemic circulation. This is the main concept. So this is what I'm talking about, the central venous oxygen saturation. So as I have told you, if the patient is normally behaving, the loading happens normally, all the berth in the hemoglobin couffet is filled up, the cardiac output is fine, there is nothing issue with the cardiac output, the tissue is getting the adequate oxygenation, and ultimately out of which only 25% is used by the tissue, 70% comes back to the central circulation. This is the basic component. For example, if the patient is anemic, obviously will not have any passengers to sit inside, or if there is an amount of oxygen, if there is a VQ mismatch, like it happens in a patient with or VQ mismatch with pneumonia, or a shunting, which like happens in a ARDS, obviously will not have most passengers coming and occupying the seat, so you will have empty trains coming to the tissue demands. So these are two things which can happen. So this I already told you. If approximately the consumption by the tissue is only 250 ml per minute, the delivery is around 1 liter, so oxygen extraction is around 25%. So this is one of the most important things which you can do at the bedside. This is a mixed venous oxygen saturation, which we can get it from the pulmonary artery, and central venous oxygen saturation is which we get it from your central venous. Like you have a central line into the SVC, which we can return. Usually, if you look at it, the normal value is under normal physiological condition, the central venous oxygen saturation is around 2 to 3% lesser than the venous saturation. So if it is 70%, this is 70%, the central venous oxygen will be sitting at 65. So basically, it's very easy to remember. You put a sample inside, you have got a central line inside, you try to take a ABG sample and try to see what is the percentage of oxygen in it. If it's around 70 to 75, that means the adequate cardiac output is happening, the tissues are getting the proper oxygenation. You may have two conditions. Either the amount of blood, that is the amount of oxygen that we see in the line will be higher, more than 75, or it will lesser. That we have to differentiate what is happening to them. I will give an example. So you are taking a sample from the central line, and you may have a decreased venous saturation. The saturation is sitting at less than 70. So it may be two reasons. Either the oxygen delivery is less, or the tissues are consuming more oxygen. The tissues are taking more. Their demand is very high. So in those conditions, I'll try to correct. Maybe the train is not there, so I'll try to correct the anemia. Maybe the patient is in hemorrhagic shock, so I'll try to correct the cause. Maybe the patient is not taking adequate oxygenation, I'll try to correct the hypoxia. Maybe the cardiac output is less, that engine is not functioning well, so I'll try to correct the hypovolemia and heart failure. Similarly, if the patient tissues are consuming more oxygen, maybe I'll try to see what is the cause for tissues taking more amount of oxygen. Maybe it's because of the agitation, pain, feverish, all this should be taken at the bedside. You may have some condition like where the venous saturation more than 75, the central venous saturation more than 75. So similarly, the oxygen delivery is very high or the consumption is very less. It may be because of these causes, this may be this. This needs to be seen at the bedside and to monitor accordingly. That is the one concept with regards to mixed venous oxygen saturation. The next important component is the PCO2 gap. You take an ABG sample, see the PCO2. Normally, the PCO2 gap between the arterial and venous sample is 6 millimeter. For example, if in an arterial sample, the PCO2 is 40, the venous sample, if you're taking the PCO2 is 46. The difference is 6 millimeter mercury. This is normal for you and me. But if you are having a PCO2 gap for more than 6, that means it suggests either the patient is needing a fluid resuscitation or inotropic support. How this concept came, why this concept came is based on the proposal by Vallet et al. I'll tell you. What he said is, carbon dioxide is about 20 times more soluble than the oxygen, so it more reliably diffuses out of the ischemic tissue into the venous effluent, making it as a sensitive marker of hypoperfusion. So in case you are taking a sample, the venous sample shows up, arterial sample is PCO2 is 40, the venous sample is sitting at 50, the PCO difference is more than 6. Obviously, you may have a condition like I may have to fill up the patient. Patient may be in a hypovolemic, or the patient may require inotropic support. This is the rationale behind the venous PCO2 gap. So most of the time, if it is a hypovolemic shock, you will have a gap will be more than 6. In case of distributive shock, like a septicemia, will be having a high CO2 gap, whereas when compared to the anemic and cytopathy, it will be on the lower side. This is one of the example of how to interpret your PCO2 venous arterial gap. When it comes to the microcirculation, hemodynamic coherence is a very important definition. Basically, I already told you is the condition where the oxygen delivery is not good enough to the tissues. So hemodynamic coherence is what we termed as the condition where we try to resuscitate both the macrocirculation and microcirculation. We try to target both the things are changing in the same time. So what they're saying is, once you try to optimize this hemodynamics, it may increase the convection flow. Basically, your transport of RBC into the tissue is good, but it may not mean that adequate oxygen being delivered to the tissues, especially if the areas of microcirculation is obstructed. You may deliver the train, but the oxygen may not, the passengers may not unload at the station. That is also possible. So what they found is, Even though you try to optimize the macrocirculation, they did not improve in a microcirculatory perforation in oxygenation. Ultimately, patients succumb to the illness. So there are multiple factors, including the hormone and neuron, biochemical, vascular, all this has to be taken into consideration when you're trying to optimize the microcirculation. What is the pathogenic mechanism? What is behind this thing? What they're saying is, it's basically the generation of the reactive nitrous active oxidative species that is going to make the loss of your vascular regulation. Endothelium is part of the microcirculation, it's compromised. In turn, it is going to lead something called as tissue hypoxemia. So the same concept, if you are not going to optimize your hemodynamic coherence, you are going to lose a patient at the bedside. So these findings suggest that microcirculatory goal-directed therapy might be a better resuscitation strategy in a critically ill patient. It's going to the future for the next 20 years. There are 4 types of microcirculation alteration. The type 1 is heterogeneity. Basically, the capillaries are obstructed. Next to a capillary is flowing with red blood cells. Conditions like 2 minutes, I'll finish off. So inflammation, sepsis, and reperfusion injury will have the type 4 heterogeneity. Type 2 is basically dilution of blood causes loss of RBC filled capillaries, most commonly seen in cardiac surgeries and sepsis because we are trying to fill them more with the volume. So this is one of the type. Type 3 is vasoconstriction tamponade. Basically, there is a vasoconstriction of the arterial vessels, so it's going to cause ischemia of a microcirculation, most commonly seen with the vasopressors and increase in venous pressures. Your inotropes. Based on the microcirculation, we can decide whether I'm giving adequate inotrope supports to the patient or not. And last one is your type 2 is for is tissue edema, basically happening because of capillary leak, most commonly seen in your de-escalation. Once the patient has been completely responded to therapy, after 3 or 4 days of ICU, you will find this kind of tissue edema, basically because of a fluid overload. So a lot of assessments has come, starting with your clinical assessment, laser Doppler flowmetry, tissue oxygen, a lot of things has come. Most commonly, the best method that is available at present is direct visualization of your RBCs in the microcirculation using a handheld microscope. This is the most gold standard now, as of now. There are multiple multiple generation comes. The orthogonal polarization spectral and the side stream are the initial one to come into existence, but this was not this was not working because we were not seeing what is happening at the tissue level. We know that some tissue perfusion is not happening, but we were not able to visualize completely. So then third generation device has come, and that is called the CytoCam IDF. Though CytoCam IDF, there is a sensor plus extra short pulsar illumination that is essential for measuring the RBC velocity. And this is helpful for direct identification of the hemodynamic coherence. As I told you, macrocirculation and hemodynamic coherence should happen to it. And it also helps for clinical decision making and titrating therapy to target your normalization of microcirculation. This is a machine which has come into existence, the CytoCam IDF. So it tries to see what is happening at the conviction level. It also tries to see what is happening at the diffusion level. There are multiple names for it. The conviction is quantified by the measurement of flow in the microvessels and diffusion by the density of the perfused in the microvessels. And they are using the software called as automated vascular analysis, which has come from the University of Amsterdam. And it also measures the total vessel density using the AVA software. There is something called semi-quantity analysis as well as a microvascular index. Microvascular index is over on the score average of the individual values. If it is less than 25, you are having a problem with the tissue level. It also measures your proportion of the perfused vessels as well as the perfused vessel density. These are all definitions. When you start using the machines, you will have an idea about the values. So this is an example. When you're trying to use points for 9% normal saline for resuscitation, you can see the capillaries are not adequately filled up. You cannot see this. At the same time, when you're trying to use an hydroxyethyl starch, the volume is, we can see the capillaries very clearly. I'm not making a statement here that for fluid resuscitation, hydroxyethyl starch is good. I'm just showing an example how the difference happens at the level of microcirculation. Don't take a wrong message, and HES can be used for resuscitation. And when you look at the capillaries, the square ones are capillaries and the circular ones are venules. This is a simple example of using a CytoCam IDF at the microcirculation level. My topic was assessment, so I am not going into the management of using a microcirculation therapies here. So to conclude, there are pitfalls and limitations for the assessment of microcirculation assessment as well as modulation of sick patients. And heterogeneity of the microcirculation vascular events is a tremendous challenge because it varies from every. We usually measure at the sublingual level. And we don't have a selective vasoactive agents which can target your microcirculation. And still works are needed to translate the observation into meaningful response. Thank you so much. Any questions? I'll take them.